Let's review the physical exam findings in a patient with tricuspid regurgitation. Hello, I'm Dr. Habibi, and in this video, I want to explain heart murmurs in simple and understandable language. So stay with me.
We use the term script, the place where the tricuspid murmur is heard the loudest. On the chest, it's at the left sternal border and the lower part of it, known as the Erb's area. The letter C stands for character. The murmur caused by tricuspid regurgitation has a blowing quality. The letter R stands for radiation. The murmur from tricuspid regurgitation usually doesn't radiate anywhere because its intensity and gradient are low, but in severe cases, it might also be heard in the epigastric area. The letter I stands for intensity. The intensity of the murmur from tricuspid regurgitation varies and depends on different factors. The letter P stands for screw. The murmur from tricuspid regurgitation is high-pitched or high-frequency. The letter T stands for timing. The murmur from tricuspid regurgitation is holosystolic or pansystolic. This means it is heard throughout the entire systole from S1 to S2. In patients with chronic tricuspid regurgitation, like those with chronic MR, an S3 gallop can be heard. But their S3 is on the right side, so we hear this S3 sound in early diastole, that is, immediately after S2. Another characteristic in a patient with tricuspid regurgitation is paradoxical splitting of S2. This means that in the heart sounds, P2 is heard first, and then after a pause, A2. Because, as you know, under normal physiological conditions, when we inhale, a negative pressure is created in the chest. Venous return increases. Therefore, during inspiration, the time it takes for the right ventricle to empty increases. That's why the pulmonic valve closes later. But in a patient with tricuspid regurgitation, when the right ventricle contracts, in addition to the blood that leaves through the pulmonic valve, a large amount is also ejected back into the right atrium, and this causes the right ventricle to empty more quickly. Therefore, the pulmonic valve closes earlier, and P2 is heard before A2. This phenomenon is called paradoxical splitting of S2. The next characteristic in a patient is JVP. In a patient with tricuspid regurgitation, the JVP is distended and the jugular venous pressure is increased. In addition, the X wave disappears and the C wave directly connects to the V wave. The height of the V wave also increases, and a new wave is formed that we call the CV wave. The next characteristic is inspection and palpation. In a patient with severe TR, because the right ventricle gradually enlarges, when we place our hand on the chest, we can feel an RV lift or heave. If you found the video helpful so far, please like it and share it with your friends. And if you don't want to miss my future videos, please subscribe. In a patient with severe TR, because during systole blood is pumped from the right ventricle into the right atrium, and on the other hand, there is no valve between the right atrium and the SVC and IVC. So this volume of blood is directly transferred to the SVC and IVC. The blood that enters the SVC presents itself as an increase in JVP, or jugular venous pressure. The blood that enters the IVC leads to hepatomegaly, splenomegaly, ascites, and lower extremity edema. In a patient with severe TR, a large amount of blood flows into the liver and causes hepatic congestion. That's why when we press on the liver, the blood that has accumulated there can flow back and enter the SVC again, raising the patient's JVP. This is called a positive hepatojugular reflux. In other words, the liver acts like a sponge that has absorbed water. When you squeeze a sponge, the water stored inside it comes out. What is the scientific definition of a positive hepatojugular reflux? If applying pressure to the upper abdomen for 10 seconds causes the JVP to rise by more than 3 millimeters of mercury and stay elevated for 15 seconds, this is called a positive hepatojugular reflux. It is seen in patients with heart failure and those who have severe tricuspid regurgitation. Another characteristic of the TR murmur is that it is preload dependent, meaning any factor that increases the heart's preload will make the murmur louder. That's why, after inspiration, when venous return increases, the TR murmur also gets louder, and after the Valsalva maneuver or standing up, the intensity of the murmur decreases.